All right, good evening. My name is Alex. I am a student here at Harper College, first year DCS. I will be presenting on chronic deep vein thrombosis at an educational approach for the Sonography Theory 2 course. So for this presentation, we will be looking at the signs and symptoms of chronic DVT, along with treatment options, disease characteristics, sonographic evaluation, and comparing chronic DVT to acute DVT. So let's go ahead and start with the abstract. So a chronic deep vein thrombosis, or otherwise known as chronic DVT, is a blood clot that forms within the deep veins, usually of the leg, but can occur in the arms and the mesenteric and cerebral veins. This blood clot has been in the body for over 28 days for it to be considered chronic. This presentation provides a comprehensive review of chronic DVT, emphasizing the key differences between acute and chronic DVT, with a focus on disease characteristics such as signs and symptoms and pathophysiology, sonographic evaluation with a close look at duplex ultrasound of the upper and lower extremities, and treatment options for chronic DVT, which includes medication and vena cava filters as an alternative. So let's go ahead and start off with the signs and symptoms. So according to Stanford Medicine, signs and symptoms of chronic DVT include swelling in one or both legs, pain, warm skin, discoloration, so a bluish or a reddish hue of the skin, and as well something interesting that I stumbled upon with my research that we learned last semester is that symptoms only occur in about 50% of patients with this condition. Also, according to Stanford Medicine, risk factors that contribute to the development of deep vein thrombosis include surgery, specifically surgery of the hip, leg, or abdominal surgery, trauma or bone fracture, a long period of bed rest or sitting for a long time, for example, being on a flight or in a car for long periods of time, cancer, pregnancy, birth control pills or hormones taken for symptoms of menopause, varicose veins, and also the main pathophysiological mechanisms involved in DVT include damage to the vessel wall, blood flow turbulence, hypercoagulability. If these three factors ring a bell, they are also known as Vickrow's triad. So these factors in Vickrow's triads stimulate local cytokine production and causes leukocyte adhesion or white blood cell adhesion to the endothelium. This promotes venous thrombosis. So these three factors together kind of join in and they really cause this condition to come up. So as well with having chronic DVT can really lead to other complications like a pulmonary embolism. This is where a blood clot, most times coming from the leg, can turn into an embolism. This travels up to the arteries of the lungs, gets lodged in there, and blocks blood flow and oxygen levels in the lungs. So that's no good. It can also lead to superior vena cava syndrome. This happens when blood flow through the superior vena cava, a vein that carries blood from the head, neck, and upper chest, could be completely blocked. A noted sign of SVC syndrome is facial edema. So the accumulation of fluid into the facial area there. It kind of looks like swelling. And finally, chronic DVT could lead to death if these complications aren't taken care of. And here you can see a picture or an image of kind of like the process of how these DVTs kind of come up. Alright, so now we're going to go ahead and go through the diagnostic tools. So diagnosis. So the diagnostic tools that are used for the assessment of DVT include imaging modalities such as ultrasound. This is the first line of imaging modality following positive D-dimer testing. CT or computed tomography, MRI or magnetic resonance imaging, elastography, and then, as we mentioned before, with the positive D-dimer test, what is that? D-dimer blood test is also the first line of testing as well. Like when a patient is admitted to the ER for symptoms such as deep vein thrombosis, kind of like one of the first things that they do is this D-dimer blood test. So this measures the D-dimer protein since it's highly present when a blood clot is in the body. And we're going to go ahead and move on to sonographic evaluation. So what do we do when we do that ultrasound? So high frequency linear probes are used for a lower or upper extremity venous duplex ultrasound exam. So the primary means of assessing venous patency is compressibility. So these compressions are really gonna distinguish between if a DVT is present there or not. So let's kind of look at the lower extremity venous duplex ultrasound. So when doing the lower extremity duplex, you're going to go ahead and start from CFV to distal calf veins. Those are imaged, conducting compressions first with transverse views. Then you go ahead and perform longitudinal grayscale, color Doppler, and spectral Doppler with augmentations to be performed. So when you combine Doppler imaging, waveform analysis can be carried out with respiratory augments to evaluate the patency of more proximal veins indirectly. For upper extremity venous duplex ultrasound exams, the sonographer starts at the origin of the subclavian vein to the wrist. So the radial and ulnar veins are imaged. The sonographer starts with distal and proximal color flow images of the subclavian vein, followed with axillary vein color flow and compressions. And finally, brachial, basilic, ulnar, and radial vein compressions are done. Also, something that I didn't mention for the lower extremity venous duplex is the veins imaged. So you go from CFV, you go to the profunda vein, you go ahead and do the SFA, proximal, mid, distal, then you go down to the popliteal, so proximal and distal, and you go ahead and go more distal to that, end up in the calf veins, so the perineal and the posterior tibial veins are imaged. So big thing when doing these venous duplexes is that the vein failing to collapse at any point is strongly suggestive of thrombosis. Now we're going to go ahead and see acute DVT versus chronic DVT. What's the difference? So biggest difference between acute and chronic is how long it has been present in the body. Acute DVT is thromboses that occurred less than 14 days ago, whereas chronic is anything over 28 days. So managing acute DVT can be easier since it is more straightforward with clot removal followed by potential stenting of a stenotic lesion. Now, a difference with that and chronic is more complex with less chance of technical and clinical success due to those scarred fibrotic veins, which may take several hours across, followed by potentially painful venoplasty and stenting, often requiring general anesthesia. Now let's go ahead and backtrack over to last semester. What did we learn about those sonographic differences between chronic and acute? So with acute thrombosis, the vein diameter is generally increased in presence of an acute DVT. So as you can see in that transverse views there, that vein diameter is pretty big right there compared to like the veins that we usually see. Whereas in chronic, we see that sagittal view there on the bottom, right about there. Vein diameter is generally decreased. So if you can see the vein right there, artery right there, that means that's a huge indicator of a chronic DVT there. Now finally, with follow-up and treatment options, You want to start the patient with anticoagulants such as warfarin, heparin. Heparin can be given injection via intravenously or subcutaneously. Treatment may last 3 to 6 months. Thrombolytics, so those two are really going to attack the blood clot there and kind of like prevent blood from coagulating, or using that as blood thinners, such as TPA, used for stroke, heart attack, pulmonary embolisms, or TN kinase, similar to TPA, but with a faster onset of action. And finally, if medication doesn't work or the patient can't take it, we use vena cava filters, which are inserted into the vena cava when these medications aren't working, a cornerstone for medicine. And here is just a final ultrasound view of what a chronic DVT looks like right in there. That is the end of my presentation. Thank you.